Thank you for your kind introduction. I was given the very hard task by IVHEM this year to discuss co-infections of hepatitis in childhood B, C, and D, the diagnosis and treatment. Here's my disclosure. So the key points for my presentation will be the global burden of viral hepatitis B and C in children, global burden of hepatitis delta, the high-risk populations for co-infection, and some case reports for co-infections, how to prevent and how to treat. So why do we need to discuss hepatitis B and C in children and even co-infections? From clinical perspective, they're mostly asymptomatic. And of course, co-infected cases are more likely to progress to liver disease and present with advanced liver disease. From the public health perspective, children are transmitters of infection. DAAs are available, they're safe, highly efficacious for treatment of Hep C. Cure of Hep C and suppression of Hep B would prevent the transmission of infection, and of course, early treatment is important before high-risk behavior in adolescents. We should consider globalization, immigration, migration, displaced children among high-risk behavior to be high risk for also co-infection. And we cannot eliminate or achieve the elimination goal by 2030, except if we include this population of children. And we should remember that some 2.3 billion children below the age of 18 years make up to around a quarter of the world's population. The global prevalence of hepatitis C of children in 2018 shows a prevalence corresponding to around 3.26 million viremic children. That's by the end of 2018. Some data were actually published data, but some of them were coming from modeling. The highest burden of disease is coming from Pakistan, less so for China, India, Nigeria. Egypt dropped after the national screening program, and the highest prevalence, more than 1.6%, is in Mongolia. The highest predictor of HCV prevalence by age group, for the younger age group less than 4, it's perinatal transmission. 5 to 14, it's iatrogenic, but 15 to 19, which is the adolescent age group, in addition to iatrogenic, also we should look at injection drug use, and that's shown clearly on the right side in some publications coming from CDC and from the US, showing an upsurge of hepatitis C and drug use among adolescents and the whole population, and increased substance use in adolescents, increasing the risk of hepatitis C. How about the global prevalence of hepatitis B in children less than 5 years of age? In 2016, this modeling study looks at 48 million children less than the age of 18 years who are S antigen positive. The majority are residing in West and Mid-West Africa, and some of them in Southeast Asia, particularly in India. The 84% of countries have implemented the hepatitis B third dose, but only 39% of countries offer the birth dose of the vaccine, and that's a huge challenge. The S antigen dropped from 4.7% in pre-vaccination era to 1.3%, but we need to drop it even further to less than 0.5%. The situation of Delta, though, in children is totally unknown. There are very few case reports with either co-infection or superinfection. We only have the global prevalence for the hepatitis Delta in adults, although also there are no good peer-reviewed global estimates according to the Polaris Observatory. They estimate around 24 million S antigen positive individuals who are co-infected with Delta. Of course, the numbers have dropped with vaccination, both for hepatitis B and for Delta. Who are the children at risk of hepatitis C and B and co-infections in low middle income countries? Those undergoing multiple blood transfusions and multiple invasive procedures, those with history of hemodialysis, children born to infected mothers with hepatitis B. They have, of course, a 90% chance of being infected with B if they're E antigen positive. 5 to 7% of those mothers who are C infected can infect their babies, and children with an infected household member and adolescents with high-risk behavior. Some of the data published, or the few cases published, are going to be shown in the following slides, spanning over a 20 years period. This is an earlier epidemiological study from Moscow for 374 children. 195 of those had liver disease, while the rest were without liver disease. Of course, the prevalence of hepatitis B and C was much higher in those with liver disease, 66% for B, around 16% for C for the liver disease population, and around 14.5% for B, 0.6% for C for the non-liver population, and the co-infection rate was 4.7% with Delta virus and those who are HPV DNA positive. In another study from Pakistan looking at children with chronic Delta virus infection compared to those who were mono-infected with hepatitis B, 48 in each group, 50 of those had undergone liver biopsies, and Delta infection was more aggressive, showing more aggressive liver disease than the HPV mono-infected cases. And when they looked at the differences in terms of age, cirrhosis, splenomegaly, esophageal varices, splenic varices, transaminases, platelet count, and the prothrombin time, INR, and the inflammation liver biopsy, as well as advanced fibrosis in the two groups, it indicated that there was more severe liver disease in the Delta group. Another study from Western Turkey had shown a 1.76% of the co-infection of hepatitis Delta in the B infected cases. And they had shown also a higher fibrosis score in the Delta co-infected population than in the HPV mono-infected population. All the mothers of the Delta cases were chronically infected with hepatitis B. So reiterating again that the co-infection with Delta gives a more aggressive liver disease and a more advanced liver disease. Another retrospective study from France, and this study included many women from African countries, and the study was between 2004 and 2015, looking at 742 HPV infected mothers. Out of those, 3% were co-infected with Delta, and they looked at the 54 children during the study periods, and of those, 36 were assessed and they were given the hepatitis B immunoglobulin. 66% of those were protected, 28% neither infected nor protected, one chronically HPV infected, but none were Delta co-infected despite co-infection from many of those mothers. Another study looking at 5 Black African children with membranous glomerulonephritis were co-infected with hepatitis B and C. They could see no difference between those co-infected cases and those who were more infected and presenting with membranous glomerulonephritis. However, the important point in this study was the fact that 24 family and household contacts were infected with either B or C or co-infected. 7 were B, 1 with C, and actually none with both viruses. So probably they acquired the infection through other routes, or their parents had a sort of a stronger or a dominant virus, so the other virus was not diagnosed for one reason or the other. Another one from a resource-limited setting in Yemen, from Taiz Governorate, for looking at 1,484 school children aged 5 to 16 years, and they had schistosomiasis, both schistosoma mansoni in around 21% and around 7.5% schistosoma hematobium, and they could see clearly that the prevalence of hepatitis B and C was high in this population, and the co-infection rate with hepatitis, both with hepatitis B as well as C, and those cases showed more aggressive liver disease. One of our earliest reports looking at the cases also with hematological malignancies, the high-risk population, we looked at hepatitis B and C, and we found that 1/3 of this population was co-infected with both hepatitis B and C, and we could see more aggressive liver disease, and including cirrhosis were reported in the co-infected population, while fulminant hepatitis and death was reported more in the mono-infected population who are receiving chemotherapy, of course, because of severe reactivations. Another study of ours later showed occult hepatitis B in children with hematological disorders and infected with hepatitis C, and overt as well as occult hepatitis B in addition to hepatitis C in the population with hematological malignancies. And we clearly could see that there are core mutations in around 30% of the hematological disorder population, core mutations in 39% of the hematological malignancy population, and we found one patient with a mutation in the X region. And this, of course, is a pre-malignant mutation. When we started treatment at that time, because those cases were having severe reactivations of hepatitis B, we started with lamivudine very early in the late 90s. We started to encounter dual infections because at that time we were not doing routinely PCRs for hepatitis C for all cases. So what we've seen is that some of the cases that received lamivudine, at that time we were biopsying patients every 18 months, they had worsening liver histology on lamivudine, and this was associated with a breakthrough with both HBV DNA because of lamivudine resistance, but also for hepatitis C RNA. And if we look at another child who was 13 years old as well, after worsening of the liver histology on lamivudine and breakthrough for hepatitis C and hepatitis B, the liver histology improved 12 months later on interferon therapy when we gave interferon in combination with lamivudine. So that proves that there is a dominant virus always, and there is an inverse relationship. And the dominant virus in the immune competent population is possibly the hepatitis C, but in the immune compromised and suppressed population, it is definitely the hepatitis B. When we looked at the differences in the co-infection population, what accounted for a more progressive liver disease was the number of hepatitis flares related to chemotherapy that the patients experienced during chemotherapy that was associated with a higher grade of fibrosis. So how about prevention and treatment? Of course, for prevention of hepatitis B and indeed Delta, we need to treat mothers in the 3rd trimester of pregnancy if they have high viral loads according to the most recent WHO recommendations. And we need to give the birth dose of hepatitis B in addition to the 2 and 3 other doses in the expanded immunization program. And the recommendations for treatment of hepatitis B, we have very few studies for newer drugs, but what is being approved for children is interferon alpha 2B is approved for children 1 year of age and older, and lamivudine and entecavir are approved for children 2 years of age and older, and we only have tenofovir for those above the age of 12 years. So this is the only salvage we have for those who are lamivudine resistant. Lamivudine is still being used in many resource-limited countries because the generics are available and it has a much lower cost. For hepatitis C, we have those are the approved direct-acting antivirals, and most recently, sofvelpetesvir for those above the age of 12 years, sofribovirin for genotypes 2 and 3, and soflidipasvir ribavirin for 1, 4, 5, and 6. And of course, sofvel is pangenotypic and GP is pangenotypic. And all those are approved for GP only for above the age of 12 and sofvel above the age of 12, but others are approved until up till down to the age of 3 years in different formulations. Those are the ongoing studies, including sofdaclatesvir from Egypt. There are many studies, including one of my studies that we recently published for pharmacokinetics of sofdaclatesvir. And of course, we have other studies for the sofdaclatesvir coming from Egypt. There is also elbasvir, grassoppervir, and we have the sofvelpetesvir, the studies down to the age of 3 years. And most recently at the ASLD, the sofvelvox also studies have been presented. This is also one of our studies that we presented last year for children with hematological malignancies receiving soflidipasvir to prevent HCV reactivations, and 100% achieved sustained virological response. So what we need to do for diagnosis and control of hepatitis C, B, and Delta in children: surveillance, infection control, for prevention, blood safety and injection safety, implementation of birth dose, and of course, universal screening of pregnant women. We need to prevent mother-to-child transmission for both hepatitis B, and that consequently will prevent Delta, education awareness, and we have to look at the gaps in research in children because we don't have many clinical trials. For prevention, for treatment, we can use cure as prevention for hepatitis C, viral suppression for prevention for Hep B, as well as Delta. We need to prevent progression of liver disease as well as stigma and reactivation in the immune suppressed population. And finally, those are the challenges and gaps that we need to look at. We need to address the research gaps. Very few case reports we have on Delta in children and co-infections. We need to prevent mother-to-child transmission and screen all pregnant women, early treatment of women in childbearing age. We need to look at the cost of the tests for hepatitis Delta. They are prohibitive in most of the resource-limited settings, and this is really important. We need to conduct more clinical trials for co-infected cases, particularly for Delta, and we look at the economics of the pediatric formulations, in addition to service delivery for the high-risk adolescent population. And finally, we need to have better screening policies for pregnant women for all viruses, and we need to consider co-infection with Delta, especially in places with high burden in the HPV-infected population. Thank you very much.